Now I request Dr. Arindam Datta, consultant.
And thankfully, my presentation is very crisp just because I have been a late inclusion into this because as you can see in the schedule, it was being supposed to be taken by Dr. Deepak Agarwal, who was unfortunately absent for today's schedule. And I will try to keep it crisp and make up for the discussions yet to come. So as far as my topic is concerned, it is arterial blood gas analysis and how I do it. Because it is something those who are not only in critical care or people dealing with ventilation settings or oxygenations, it is something pertinent to all of us day in and day out. Because arterial blood gas is a very common topic, but often being misinterpreted. It's a basic and it's the basic where we falter. So coming to my topic, so this will be the headings I will be going through, and of course I will skip the clinical case scenarios for the workstations. So now the indication of the ABG, which I think I need not highlight more. Okay, so we are doing it day in and day out. It's aid in the diagnosis of a critical patient like electrolyte imbalance or acid-base imbalance, and also it helps in the fluid and electrolyte balance. So as far as whether the fluid and electrolyte resuscitation is concerned, or even when we plan a dialysis or something, and also as far as drug is concerned, so as Dr. Sudipto Mukherjee has told already that the antibiotics and all are being decided on the PD and PK. So it is the acid-base milieu of the patient that helps us to decide our choice of drugs, which are we are going to give for the optimization of that patient. So now this is more important than the indications, because so common contraindications for ABG involves that is cellulitis or other local infections. So we don't end up in a case of frank septicemic case, and it is also absent arterial pulse. Coagulopathy is a relative contraindication to me because in a patient of sepsis there can often be coagulopathy, yet we need to do the ABG and we need to take proper precautions. Absent collaterals and arterial grafts and dialysis shunts, which are being encountered often, and in that case it is advised that you need a separate site for the prick. And history of arterial spasm after puncture, it is also a relative contraindication, and severe peripheral vascular disease. So errors, like any test, are inherent part of the ABG, and the problem with ABG is that ABG is susceptible to errors both pre-analytical and post-analytical. So on the post-analytical part, that we can master by interpreting more and more ABGs, but the problem is with the pre-analytical part, because in most of the ICUs, we medics don't do it ourselves. We have our brothers or sisters or technicians doing it, and when we are interpreting it, unless and until we know that what are the pre-analytical errors, we can't take it with a pinch of salt. So the pre-analytic errors can arise from various factors like the wrong identification or labeling of patient samples. It may be inappropriate anticoagulants like the citrate or EDTA, which is usually acidic in nature and therefore interfere with the pH estimation, and also with the heparin, because most of the times due to cost constraint we use normal heparin, just dilute it just flush the syringe with the heparin, and that leads to dilution, binding of electrolytes. That's why the classic teaching is that never trust the electrolyte report of the ABG, send it to the lab. So it is mostly due to the heparin binding, and also there may be insufficient heparin leading to clotting of the bloods. Now coming to the story, other things, that is inadequate stabilization of the respiratory condition, because we often jump up on an ABG after putting a patient on oxygen or changing the ventilation settings, which doesn't allow us to reach the equilibrium. And also inadequate removal of flush solution, and venous or mixed blood sampling is often more common than ever, and also the air bubbles. So the preferred site for ABG while sampling for the blood is that it is a radial followed by brachial and femoral artery. We can also take it from the other large arteries or easily palpable arteries like the arteria dorsalis pedis. So ensure scene safety first, and no ABG should be taken without a recording of the clinical history. Suppose you end up with a ABG with a high metabolic acidosis and you don't have the clue that the patient is on metformin. Okay, so actually it is expected that the metformin patient who is on metformin is going to have some sort of metabolic acidosis. So you need to have this detailed clinical history, especially the drugs, and also record the oxygen status by noting the FiO2. Allow equilibrium to be reached at least 20 to 30 minutes. 20 minutes in case of room air, and if you change the ventilation settings, at least allow 30 minutes. For radial artery, ensure collateral circulation by modified Allen's test. Standard disinfection procedures to be followed. And ideally, it is the pre-heparinized blood gas syringes, which we don't use too often because this comes a bit costlier. But it is actually pre-heparinized blood gas syringes which have a fixed mark that you need to take blood up to that mark, just like the P-time vials we used in our residency days. Because if you take less than that amount of blood, it will lead to dilution. If you take more than that, that will lead to clotting of the blood. And glass syringes are preferred if you keep it more than 30 minutes, because plastic syringes alter the PO2 and the other variables. So this is the modified Allen's test. So the picture is depicting itself. So I would like to skip this slide. It just needs to check the collateral circulation of the radial artery. If your radial artery has good collateral supply from the ulnar artery, we can safely go for the ABG from the radial side. Now, coming to the sample storage and preparation, because this is also as vital as sampling for the ABG. So we do not recommend cooling the sample if the because ABG is actually a point of care bedside test. Okay, so if it is a point of care and bedside test, it doesn't require storage and transportation anything. So there should not be any time delay in the sample. So cooling is usually not recommended. Analyze within 30 minutes or even within 5 minutes if there is high chances of utilizing O2 in between. That is, we have a very high TLC or a very high platelet count. Okay, in that case, these cells consume a whole lot of oxygen and the PO2 will come down. So if delayed by more than 30 minutes, the transportation needs to be in a cold chain. So what we need to do is that for mixing, just invert the syringe for 10 times like this, so that there is a proper mixing, and rub in between pumps. Okay, and after this, check visually for any clots. If there are clots, discard the sample and go for the next another sampling. Now coming to the interpretation of the ABG, most of the ABG machines nowadays operates on a Stewart strong ion difference method. Okay, there are other methods as well, but there hasn't been much difference. And this Stewart strong ion difference, this is comparatively much precise method and doesn't need much sophisticated softwares like the other ones used, because previously before this sophisticated machines, people used to use nomograms and all, and that was a hell lot of complicated procedure. Now with this strong ion difference method, the machine does all the sophisticated calculations for us. It has predefined protocols fed into it. So once we land up with the ABG report, we just need to follow 6 steps. That is the standard 6 steps of ABG that we will follow. Okay, so the first step, it is the base of any ABG, that is the Henderson-Hasselbalch equation. So Henderson-Hasselbalch equation is the basic equation of the acid-base equilibrium in our body. So what we do is that we take the concentration of bicarbonate and the PaCO2. Before that, can I ask you a question that what are the main parameters or what are the primary parameters we need to have before analyzing a acid-base disorder patient? Any idea? What are the very basic parameters I need to know? Anyone?
PCO2, H plus, and bicarbonate.
Other things? We need the electrolytes as well. Okay, so because acid-base disorder balance, acid-base disorder, things cannot be approached without having proper electrolytes level, because we need to calculate the anion gap and all if there is anything like that. So the H plus, that is, we get the H plus in the form of pH in a ABG report. We get the concentration of H plus in a milli equivalent per DL or something like that. So for that we need to convert the pH into the hydrogen ion concentration. Bicarbonate concentration and PaCO2 we get directly from the machine, and we need to cross check it by this Henderson-Hasselbalch equation. Okay, so this product of hydrogen ion concentration and bicarbonate upon PaCO2 should be something around 24. Okay, now how to have that hydrogen ion concentration? So it is a working formula. You can memorize it or just use by your own, that if you have a pH like 7.24, okay, the number after the point, that is 0.24, okay, you deduct that from 80, you will get the rough estimation of hydrogen concentration. Also you can follow this chart, okay, you can have this handy in your ICU or wherever you are doing the ABG. So from the pH you can guess the actual concentration. Now once this step is done, we move on to the next step. So if it is valid, we move on to the next step. If it is not valid, we send for a repeat sampling and recalibrate the machine as well, because a machine calibration is also very much necessary while doing an ABG. So the first step is that, with the first step, the second step is that whether it is we are living with an acidemic patient or an alkalemic patient, because this is usually the primary disorder, because the pH is the last thing to change in an ABG. So, and as it is the last thing to change with the very early stage of acid or alkali disorders, pH even might not change while we have frank acidemia or alkalemia in the patient. So pH anything more than 7.45 is alkalemia and less than 7.35 is the acidemia. Now here we have this rule of thumb for us, that the same direction and the opposite direction rule. So in the step 3, after we decide that it is the acidemia or alkalemia, the next step is that whether it is a respiratory acidosis or a metabolic acidosis. So for that we look at the pH and PCO2. So if the pH and PCO2 moves in the opposite direction, it is respiratory, and if the pH and PCO2 moves in the same direction, that is metabolic. So I think up to this part it is easy. So we can arrive at just by at a glance at the ABG, we can arrive that this is the acidosis or alkalosis, respiratory and metabolic. Now comes the tougher part. So it is look for the compensation. So we have the primary thing, and once we have the primary thing, we can know that what the compensation we are expecting. So if there is any appropriate compensation for the primary disturbance, it can or it cannot return the pH to the normal range. Usually if it is mild, it returns, but if it is very high, suppose if a PaCO2 in a patient is more than 60, the chances of returning the pH is hardly less than 15%. So if the observed compensation is more than the expected compensation, we need to suspect something mixed disorder. A mixed disorder, it can be a respiratory acidosis with a metabolic acidosis, it can be a respiratory acidosis with a metabolic alkalosis, or vice versa. But only two things are mutually exclusive, that is the respiratory acidosis and respiratory alkalosis, that cannot occur in the same patient, because the respiratory thing we define solely on the PaCO2, because PaCO2 cannot be high and low at the same time in a patient. So there are numerous formulas in the circulation, numerous formulas are used for the compensation. There is 1-2-4 law, 1-2-4-5 law, 1-3-5 law. Okay, but the thing I have presented here is from the American Journal of Respiratory Medicine and Critical Care. It is the most popular formula. So the formula, you need to learn it by heart, you need to memorize it by heart if you are going to see the compensation. So as far as the change in respiratory acidosis is concerned, so increase in bicarbonate is change in PaCO2 by 10, that is if acute, and just 3.5 times of it if it is chronic. And also in the alkalosis, the decrease in bicarbonate is equal to twice that of change in PaCO2 by 10, and also 5 to 7 depending upon what is the duration of compensation. So the more it is compensated, the more the longer the compensation is, a chronic COPD, a chronic retainer, chronic respiratory acidosis. In that case, we should go towards the 7 times of the change in PaCO2 by 10. So this part is calculating expected compensation for respiratory part is easier compared to the metabolic component. So the metabolic acidosis PaCO2 is equal to 1.5 into the bicarbonate concentration plus 8. It can vary up by up to plus minus 2. And also in case of metabolic alkalosis, the increase in PaCO2 is equal to 0.6 into concentration of change in bicarbonate. So with this DDS job, we have nowadays softwares telling for us, we have smartphone apps telling for us the compensation with us nowadays. Now, if we have this acidosis or alkalosis, then the next step is that if it is an acidosis, we need to calculate the anion gap. So how the anion gap is calculated? The anion gap is calculated, actually this measured strong cations minus strong anions. Okay, so this anion gap is actually the weak anions which are not often measured. Mainly the buffer systems like the phosphate buffer, the protein buffer. So the normal anion gap is approximately 12 milliequivalent per liter if we don't take the potassium into consideration, because potassium, the extracellular concentration of potassium is negligible, so it contributes very less to the total osmolarity or the total active moiety in the blood. So once there is the we calculate the anion gap. The anion gap, the problem with anion gap is that the anion gap relies on the fact that it takes into consideration that albumin and the other things, that is the buffer systems, they are in the proper level. But in case of hypoalbuminemia or something like that, it is the anion gap approach is not that much reliable. So in that case, if the anion gap is elevated, we need to calculate the osmolar gap. So the osmolar gap is the measured osmolarity minus, as you can see, the osmolarity due to sodium, glucose and Ban. Now once we have done the gap, if it is a normal anion gap, if it is a high anion gap, okay, then we need to calculate the gap ratio to know what exactly this metabolic acidosis is. Is it uncomplicated or is it complicated by some other acid gas disorder? So for that, what we do is that we check the gap ratio, that is the delta ratio as you may call. It is the change in anion gap, that is the gap of the anions, that is the from the, suppose you will end up with an anion gap of 24. Okay, so your change in anion gap is 24 minus 12 by it is 12, and your change in bicarbonate. So suppose your change in bicarbonate is 2. Change in bicarbonate is 24. So we need to calculate the delta gap. So delta gap would be coming something like this. It is 12 upon 24. So it is less than 1. Okay. So if it is less than 1, then a concurrent non-anion gap metabolic acidosis is likely to be present. But if it is more than 2, then concurrent metabolic alkalosis is likely to be present. And between 1 and 2, it is usually normal or to be judged in the current clinical scenario you dealing the patient. So these are the frequent causes of respiratory acidosis we commonly see in our critical care setup. You can have those numerics like the mud pillars, hard up also for the metabolic acidosis, but for the respiratory acidosis, we don't have such numerics. So I am not going into the details of this because this is a whole lot, and this list is not exhaustive as well. So the frequent causes of metabolic acidosis, the most important is the methanol intoxication, uremia, diabetic ketoacidosis, all these things. So any organic acid when ingested, or we produce organic acid due to sepsis, it leads to elevated anion gap. Cause this elevated anion gap, cause these are weaker acids, and we don't measure that in our day-to-day practice. And the normal anion gap, it is mostly commonly due to loss of bicarbonates, like the high nasogastric secretion, like the high output diarrhea and other things. Now the frequent causes of metabolic alkalosis, it is also vomiting or gastric suction. So where we lose fluid from our upper GI tract. And one of the most important is the renal fluid loss, like the diuretics. Now coming to the approach to the respiratory disorders, or how to approach a cases of respiratory and metabolic acid-based disorders. So with the respiratory disorder, once the primary disorder is confirmed to be respiratory, the ratio of change of H plus to PaCO2, and the other is alveolar arterial gradient and the limits of the compensation. So if the change in hydrogen ion concentration and change in PaCO2 is less than 0.3, it is chronic. More than 0.8, it is acute, and in between it is acute and chronic. So this is the alveolar arterial oxygen gradient. We need to calculate it once we have hypoxic patients, cause this will help us in narrowing our causes of differentials. So I am not going into how we calculate the alveolar arterial oxygen gradient, because I think it is known to most of us. Now if the gradient is less than 20, it indicates extrapulmonary causes, and hypoxic respiratory failure can be with normal arterial gradient or increased arterial gradient. So in a case of respiratory failure, if we see that the PaCO2 is increased, we can infer safely that the patient is being hypoventilated. And if the next thing we look at this in this patient is the arterial gradient. If the gradient is increased, it is hypoventilation plus another mechanism, and if it is not increased, it is hypoventilation alone. So in that case, it can be due to neuromuscular disease or also due to decreased respiratory drive. Now what if it is PaCO2 is not increased? So it is only an hypoxemic failure. So the PaO2 is if the gradient is increased or not. If the gradient is increased, if the low PaO2 correctable with O2, if it is correctable, it is the VQ mismatch that is leading to the hypoxemic failure. If it is not, there is shunt. So we have our differentials according to this flowchart. And if the gradient is normal, so it is decreased PaO2. So the patient is having living in a hypoxic environment, that may be due to decreased FiO2, may be due to high altitude, or may be due to overcrowding, and like many things. So these are the broad differentials of the extrapulmonary causes of respiratory failure, of which the nervous system are the main, and hypophosphatemia, muscle fatigue, these are particularly important in long-term nutritionally deprived critical care patients. But this compensation depends upon the integrity of the organs, mainly kidney and lungs, as well as the severity of the acid-base disorder. And respiratory compensation occurs faster than metabolic compensations. Acute compensation occurs in 1 to 6 hours, and chronic takes 1 to 4 days. Now coming to the approach to metabolic disorders. So this is a normal anion gap acidosis. In a normal anion gap acidosis, we also need to look at the urinary anion gap. So we need to send the urine sodium, urine potassium, and urine chloride. So we like in blood, we can't negate the effect of potassium here. So if we see that the urine anion gap is positive, then it must be due to renal cause, and if it is negative, it is extrarenal cause. So once it is due to renal cause, we need to see the pH of the urine. If the urine pH is on the more on the alkaline side, it is more than 6, it is a type 1 renal tubular acidosis, and if it is less than 5.5, it is associated with hypokalemia, it is type 2 renal tubular acidosis, and if it is associated with hyperkalemia, it is type 4 renal tubular acidosis. So I have already highlighted the first point. However, also the pH, change in pH changes the anion gap. So normally the anion gap is equal to 2 into albumin in gram plus 0.5 into phosphate in milligram per dl. Okay, so this is the change in the anion gap. This is not normally the anion gap. This is the change in the anion gap due to effects of albumin and phosphate. And once we are dealing with a patient of hypo or hyperphosphatemia or hypoalbuminemia, we need to figure this correction in our ABG interpretation of the anion gap. So the approach to the metabolic alkalosis, it is comparatively easy than the metabolic acidosis. What we need to do is that we need to check for the urinary chloride. Okay, so if urinary chloride is less than 20, it is a chloride responsive metabolic alkalosis. Causes are mainly GI loss like vomiting, diarrhea, and also diuretic and post hypercapnic patients. And if it is a urinary chloride is more than 20, the patient is less likely to respond to chloride therapy, and in these cases may be due to severe hypokalemia and also endocrine causes like mineralocorticoid excess, which may be primary hyperaldosteronism, Cushing syndrome, and ectopic ACTH secretions, and also secondary hyperaldosteronism like the decompensated cirrhosis or renovascular disease and a malignant hypertension. Now, complications of the ABG, it can be pain at the local site, bruise, hematoma, spasm, especially in patients who have previous history, AV fistula, nerve damage, infection, air and thromboembolism if not done correctly. Now, this is a very recent article, probably July 2022, from the European Journal of Research, which shows that even with these many complications and doing it so very often, even with untrained manpower, the quantum of complication is extremely less. That is, all the major things that happens in 0.14% only. That is, in this study they have showed that only 669 complications, both major and minor, taken. Okay, in 47327 patients which have been, this is a study from Denmark, and that thing fairly gives us confidence to do it routinely. Without, if we follow the basics, I don't think that there will be much of complications. Thank you.
Okay, open to question.
Yeah, sure.
I hope you must be having a lot of questions on interpretation and a lot of things.
Actually, it is tough to have from this presentation questions, if any. When we deal with the ABG in the workstation, there will be a lot of doubts.
Actually, one of my queries, like as you have told that in some acute situations we don't get like that pH changes. Okay, but as far my understanding that in acute cases actually we get pH changes more predominantly.
I didn't mention the term acute. I mentioned the term early.
Okay, in early. Actually, in compensated or chronic cases, we don't get that much of pH changes. It may be near about normal.
But also the pH, change in pH needs time, okay, especially in the metabolic. So, in the early changes, and obviously if it is not compensated in the early, and if it is compensated then in the late, particularly more in cases of respiratory, we get the pH return to normal.
And another things actually, that's to also actually, as we have read from that anesthesia time regarding metabolic alkalosis, the compensations, as you have told from American actually the equations, but as we have read, it is like 0.7 into bicarbonate plus 21 plus minus 8. That is actually, I think there are many equations.
There are many equations, and the beauty of these many equations that they don't create actual much difference when you properly calculate the extent of compensation. They somehow lead to the figure which is nearby.
So actually we may choose means
You may
any
choose
one of-
anyone. You may choose anyone.
Okay, thank you.
There are workstations, so I think how to be more clear. Now, yeah.
Thank
Just
you,
stay
sir.
here for-
Now I request Dr. Anirban Karmakar, sir, to felicitate Arindam Datta, sir.